Good morning, you guys. I'm just coming to you live with nobody in my audience once again to be able to talk about our little Q&A for musculoskeletal. So we'll just walk through the objectives like we usually do, see if it can kind of give you some focus points. So objective 8 is identify the clinical manifestations and therapeutic management of patients with osteomyelitis. So remember that osteomyelitis is a bone infection as opposed to your fractures or your complications of fractures, cast, traction, that kind of thing, that it's an infection. And so the bacteria that causes it, 90% of the time it's bacteria. And it can come from blunt force trauma. It can come from a fracture that has broken through the skin, or a fracture that's a higher risk, but it can come from a fracture that hasn't necessarily broken through the skin. And it can also be migratory. So remember that you need to get a really good history because sometimes it comes after an infection somewhere else in the body. So clinical manifestations for it, what does it look like? If you have an infection in your bone, what is it going to look like? Is it going to be hot or red? You're going to be running a fever. It might be painful. Since it's in those long bones most of the time, sometimes they won't be able to put weight on it, and they can feel very sick, have that fatigue and malaise. When you look at your therapeutic management, what are you going to do? If it's a bacterial infection, what's one of your number one interventions? Give them antibiotics. And how long and how often? And what route? So you're looking at minimum 6 weeks IV. If they're doing less than that, that is not best practice. So just make sure you would question an order if it was starting out to be less than 6 weeks of IV antibiotics. And then think about your other things. They're in a lot of pain. They have a fever. What are you going to do for these things? And what are you going to watch for with them? And what are your assessment pieces that are going to go into that therapeutic management? Number 9, differentiate between the various types of fractures. So we had several different fractures that were listed on there with different pictures. There will be 2 x-rays on the test that will tell you, that will give you a picture, and then you have to differentiate what those fractures are. But it also says, let's see, the next one's possible complications. So we'll stay on this one for a minute. When you differentiate between various types of fractures, think about some of the complications that come from them. If you have a displaced fracture, then what are some of your risks if those bone pieces slide together? What about an open fracture or compound fracture? That's coming through the skin. What does that put them at higher risk for? Number 10 is identify possible complications associated with fractures. So when a bone first breaks, it can go right through muscle and tissue and vessels, can do all kinds of neurovascular damage, can do muscle damage. So when you have any damage to anything, you're going to have swelling. Swelling in that area can cause big problems if it's swelling within the muscle fibers. And that's where the fascia kind of keeps those muscle bundles and those muscle fibers pretty secure, so there isn't a lot of room for swelling. When they do have swelling in that muscle bundle or in that fascia, it can be very painful, and it can cause compartment syndrome because it's in that little compartment of that muscle bundle, right? And so what are some of your things that you would watch for? If you had a patient that just had a fracture, and maybe they're there on your unit and they just had an ORIF, that's that open reduction internal fixation, what are you going to watch for in that arm or in that leg? What are your cares that you're going to do? Well, you definitely need to be doing those neurovascular checks or those CMS checks. Remember your 5 Ps that go into that and how they cover your circulation and your sensation and your motion, and how each one of those covers one of those CMS check areas. So when you're looking at that, you've got 5 pieces of your circulation. So make sure that you check all 5. Make sure you're checking for a pulse. Make sure you're checking a cap refill, their temperature, their edema, and their color of their fingers. Are they warm and pink? What's their cap refill like? What about a pulse? What if you can't get a pulse? What are you going to do then? I hope you said you're going to get a Doppler, because you really want to get a Doppler before you go call your physician and say you can't find a pulse. Put a little bit of gel on the end of that, put it on a pulse point, and see if you can find it. If you can, mark it with a skin marker or like a Sharpie so that other people can find the pulse there. And then if you can't, or if your cast goes over your pulse point, make sure that you're relying on those other 4 pieces of circulation. But don't forget that those are only the C in CMS, and that you have your motion or movement and your sensation. When you're checking your sensation, you need to do at least 2 different points, but it's really helpful if you go down the outside of the thumb, through the web, and down the outside of the pinky. That covers the 3 nerves that innervate the hand. And then with their motion, make sure they can flex, extend, hyperextend those fingers. See if there is an increase in pain. One of your P's in your 5 P's is pain. And so you want to look for any unrelieved pain, or if they're going backwards. So if they had some good pain control and now all of a sudden you can't control their pain, that is a sign of poor circulation, and that things are getting stopped up in that muscle, and that they might have compartment syndrome. So make sure you're doing good CMS checks, and that you're using that Doppler, and that you are, watching for any pain and paresthesia. Paresthesia, remember, is that numbness and tingling. That'll go into your sensation. And you've got your pulse, and paralysis is part of your motion. And then you've got, oh gosh, what's my 5th P? Pain, pulse, paralysis, paresthesia, and pallor. So that's your color, and that will go into your circulation. So when you're thinking about those 5 P's, think about how they feed into the CMS check. That will help you kind of remember what they are. And then when you look at the next, and then complications. So then you also have your complications of a fat embolus and of crush syndrome. And then we talked about compartment syndrome. So with crush syndrome, what's the pathophysiology of that? What's happening when we are crushing someone? Are they getting good oxygen to their tissues? No. So when they don't have enough oxygen, they kick into anaerobic metabolism, and they're metabolizing without oxygen, which can cause a buildup of lactic acid in the muscle. But then you're squishing those cells, and those cell membranes become more permeable, and they start to leak. They leak out potassium. They leak out myoglobin. They leak out toxins and purines and all kinds of things that are not good for the muscles or the vasculature that belong inside a cell. Then once they remove whatever's crushing that patient, they instantly add circulation, and they now circulate all of that stuff throughout the rest of the body. So think about what happens when we circulate myoglobin. Myoglobin can lodge in the kidneys, in the renal tubules, and it causes terrible problems with that, and can cause kidney failure or an acute kidney injury, at least. Myoglobin really is difficult for the kidneys. It can cause that rhabdomyolysis, or rhabdo for short. Potassium. What happens when we circulate large amounts of potassium really fast? They can have dysrhythmias. They can even have an MI, or they can have an irreversible dysrhythmia that can't be shocked back into a normal rhythm. Then you also have, so what are the things they're going to do about that? As soon as they take that, whatever's crushing them, off, they need to put them on an ECG, right? Or do an ECG and put them on a telemetry monitor. Make sure that they are keeping track of what that heart is doing. Make sure they're giving them some fluids to be able to flush things through their kidneys. Make sure that they're aware of these problems that can go with crush syndrome. and then monitor them. The nurses accepting them into the hospital need to be aware of these things too. Another complication is a fat embolus. Think about where that comes from the most. If we have fractures in our long bones, we have a lot more bone marrow that is exposed and a higher risk of having a fat embolus. When that small amount of fat lodges into the microvasculature, then it causes damage to those tiny blood vessels, and that decreases oxygen to certain parts of the body. So it it comes in a very specific way. And that's the little acronym R&R that I gave you. Everybody needs some R&R. It comes with respiratory, then neuro, then rash. So respiratory, what is that going to look like? If we can't breathe very good or we're not getting enough oxygen, the patient's going to be anxious. They're going to be restless. They're going to need some oxygen. Will they end up having crackles in their lungs? No, because fluid isn't going to change. We're blocking the vasculature. We're making it so gas exchange can't happen. And so they will go into acute respiratory failure, or that ARDS, acute respiratory distress syndrome. About half of these patients will need to be ventilated. So you really need to watch closely if they have a long bone fracture for signs of a fat embolus. It can also lodge in the brain. So after the respiratory is the neuro, and it doesn't hurt them. They don't have a headache or anything, but they just they can have stroke-like symptoms. They can have a level of consciousness changes. They can have seizures. The nice thing about this is that with the respiratory, it's reversible, and with the neuro, it's mostly reversible. We're talking high 90% of the time. For these, very seldom do they have residual problems. And the last one is a rash. If you're blocking microvasculature, what are you damaging? You're damaging your capillaries. So if you're damaging capillaries, what are you going to see? Probably not full-on bruising, but lots of little petechiae. Sometimes in the conjunctiva of the eyes, like in the sclera, sometimes in the nails, often upper body, skin folds, that kind of thing. You can end up seeing that petechial rash. Our next one is identify appropriate nursing care or teaching for the patient with a cast. Think about all those things that we don't want them to use a blow dryer on warm or hot for sure, right? Because they can end up burning them. Always on cool. Make sure that they're not scratching down inside their cast. And if it really itches, what are we going to do about that? How are we going to teach them to get around wanting to itch or wanting to fashion a hanger or something like that to itch down in their cast? What are we going to teach them about keeping it dry? Or about turning a patient in a spica cast? Or pressure releases or elevation for an arm or for a leg? Making sure that not only it helps decrease pain and inflammation, but it also, those changes in position will keep from getting any hot spots, any injury spots. And make sure that they know that they're watching for pain. If pain gets worse or it's unrelieved, then that can be a problem, especially if they had good pain control prior to. One part of that is identify appropriate nursing care for patients with a cast. That also includes our CMS checks. That also includes our teaching and the things that we do for it, the elevation, the ice, and then cast care. Cast syndrome. That's one of the things we need to teach our patient about, right? They have a spica cast. It covers clear up to their belly. And sometimes a physician will cut a window in the cast so that they have a little bit of extra room to swell if they need to. But most of the time, we have got to prevent constipation. About a quarter of these patients can die from cast syndrome if we don't prevent constipation. So make sure you're doing that, teaching to them about fiber and about fluids. These kids aren't very mobile, so we've got to combat it where we can. The last one, identify appropriate nursing care or teaching of a patient in traction. So think about the traction presentation. He did a beautiful job at nursing diagnoses and about things that you would do, watching for a little 8-year-old that has that's in traction, and making sure that they have the interventions that they need, but also looking for things that they would need to do while they're in traction, so that they're not just laying there. So that was good to identify that. What else with traction? Do we roll them? Do we change positions? Do we do range of motion? Do we do all of these other things? Or do we let them lay as flat and still as we can? So that begs the question, how do you move them? How do you reposition them? And you can take hospital pillows, they're pretty flat anyway, and just tip a hip or a shoulder and slide it just barely underneath there. That'll be a good pressure release for that hip, for that coccyx, that shoulder blade, and then you can do it to the other side. Before you put a patient down on a bed in traction, you need to put something else over the top, like one of the inflatable mattress covers that can have the pressure changes, or they will put them like on an egg crate mattress or something like that over the top to keep them from having breakdown. They can be in traction for half a day. They can be in traction for days. It depends on what they are trying to do before they do surgery, or how soon they can do surgery. So if they're in traction for several days, or even just a short period of time, what are we going to do with those traction weights? How are you going to care for them? What are you going to make sure happens or doesn't happen with those weights? And so you need to be looking at their positioning. You need to be looking at where they are on the bed or the floor. Are they hanging freely? All of those kinds of things. And telling family that they can't move them, adjust them, change them, anything like that. I think that's about all of the questions that you guys might have on some of the objectives there. Hopefully that helps you break them down, make them easy to understand, make them easy to be able to use to study. And so I hope you guys have a good rest of your day and a great weekend. And I will talk to you later. Peace out.